That came about when we were in mechanic school, and they needed gunners. The commanding officer of the training squadron that I was in happened to pass me. Why don't you go over and go to flying school? I said, no. He says, no, go ahead, go take the physical. He says, besides, if it's only going to take you an hour to either get rejected or passed, and then you get the rest of the day off. I'll say I'll go.
Sounds like a good plan.
So, and then the number of people that went over to take the physical was something around 55. Only 3 made it, and I was one of the 3.
Wow. So what was that like? What did you have to do?
There's certain things that you had to do, particularly your eyes. You had to have good eye coordination, and you couldn't have any stigma or anything where this is what they actually said. And then you had to have a keen sense of depth perception. And they had a tricky way to do it. They had a long table and with a piece of cardboard up here, and there were 2 sticks sticking up. And you had to take these 2 ropes, and that thing may be 50 feet away. You had to get them 2 sticks almost even. There was a certain percentage that you were allowed. If it were this, you flung. But on this way, your depth perception was good. There was a markers on there that they marked, and this is what made you eligible to go fly.
And you said you were in mechanic school at the time.
Yeah.
And where was that?
That was at Goldsboro, North Carolina. The Seymour Johnson airfield that they had just built. And from the time I was first went to the recruiting station until they called me, there was 3 or 4 months there that took for them to have room for me to go to mechanic school. So when you come out of mechanic school and you're going to be on a bomber, why that qualified you to be a flight engineer. So that's what I ended up being. But after I finished mechanic school, I went to gunnery school. We had to get up and be able to fire guns, and had all kinds of guns, handheld guns, 45s, and then you had to be, you were put into a turret on a truck, and the turret would be movable by little hand grips by electric, and you had to shoot at skeets. Before that, we were with a handheld shotgun, and I pride myself because I really make good scores on that. Because
so they even tested you with a shotgun to be an airplane gunner?
That's the start. To give you the idea of what it was, and if you knew how to do things, how to prepare yourself for it, because right in the beginning, when we started to shoot skeet, all these people that were there and training were all from South Philly or South New York or Brooklyn or something. Mm-hmm. And what do we know about shooting a gun and everything? And one thing we had to learn in gunnery school is that you can only hold a skeet, a gun, in a certain way. You can't hold it up in here like it here and pull the trigger because it'll bounce back and hit you. And on the first couple of days, people come in with black and blue mark all over their shoulder where they didn't put the gun back here and then pull the trigger. little things like that that you were taught how to do things. And the same way with all people in the crew. The pilots were at pilot training. They had to learn to. They never saw an airplane, knew what it was to, let alone take one off and land it, and still be able to use it after you land it, instead of hitting it too hard. But the bombardier had to learn how to use a gun sight, drop bombs from 4 miles up, and then being an engineer, I had to go to engineering school, and this was all, well, actually, the school was actually in the airplane, and with all of the equipment in there, you had to learn how to not only be a flight engineer, you had to know everything about the airplane. In fact, you had to teach the pilots how to, what everything is for. Yeah. The flight engineer had mainly had the somewhat knowledge to say when you go out and you have a malfunction in one of your instruments, you have to decide whether it's the instrument is a bad instrument, or whether something else is going to happen. So let's just turn around and don't go on a mission. So the responsibility was pretty, and mainly transfer fuel in case an engine gets shot out, and transfer the fuel from here to another. Because a lot of people couldn't learn how to transfer fuel. They then shut all the engines off.
So you were in engineer school, you say,
right?
And then you took the pilot test.
Yeah.
So how did that affect what you were going to do? The fact that you passed the test, that you were one of the 3 guys to pass the test.
Well, because you're the third in command, and the pilot and co-pilot, and the flight engineer is the second. So what happens to both pilots? You're going to have to take the airplane in.
So you would be prepared to do that,
or fly it back, and then everybody bail out, close to your base and everything.
So how long then? What did you do? So you went through engineering school. You said you passed the pilot test. What did you do next?
Well, what next did I do? We went out and flew over down through the Caribbean and Trinidad and Belém, Brazil, and down to Fortaleza in Brazil.
Now this was more training?
Well, it's still training, but you're flying halfway around the world till you get over to Europe, where the fighting war was.
So at what point did you have a crew at that point, or were you just?
Yes, I did by that time, and it was interesting that the way another school that I was sent to was down in Baltimore, the Glenn and Aircraft Factory. They were building the Martin B-26 bomber. It was a twin-engine bomber. It was a high-speed bomber, and it was very capable of doing things. And when I left there and had to go to Salt Lake City for a crew assignment, and when I went in to see the assignment officer, he said, well, what's your specialty? I said, well, I just come out of the B-26 factory. Well, I would assume I'm going to be the flight engineer on a B-26. And he looks at me and said, what kind of engines does a B-26 have? I said, has Pratt & Whitney he says, what kind of engines are on a B-24? I said, Pratt & Whitney. Good. That's where you're going. Why? Just wait, wait, get out. I went on to a 4-engine bomber. That was my assignment. And when we got there, I ran into another fellow that I was friends with from all the different schools we went through. We both went on the same schools. And I said, hey, Randy, come on. I said, there's a list over here. They need 2 mechanic gunners in here on this crew. He said, let's go through the war together. We've been all this way, all the training. So let's go through the war now. Okay, all right. So we both got on the same crew.
So you were able to do that. You were able to get one of your friends on the same crew.
Yeah.
And how many people are in the crew?
10 men on the crew on a B-24 Liberator.
A Liberator, it's called.
Right.
So who else was on your crew? Is that when you met all the other 8 guys as well?
Yeah. Yeah. After we met them for the first time, we seemed to hit it off, and we did have an exceptional crew. None of them were no wise guys or anything, and except the bombardier. I think he was born being PO'd.
But a good crew overall.
Yeah.
So what happened? Did you guys fly right out of Salt Lake City?
No. We went from Salt Lake City. We went down to Tucson. That was the first airfield that was training crews for B-24s. We only spent 3 weeks there. We were flying 10 hours a day.
Out of Arizona.
Yeah, and flying all around. We were doing going around strafing fields in the desert and bouncing around, getting air sick, and getting accustomed to bouncing around. Then we'd do high altitude flights, long range navigation, which would get us used to wearing an oxygen mask all the time. And that was important to be able to know when something's wrong with your oxygen, make sure that you repair, because you're up at 20,000 feet. Before we went through, started the high altitude flying and training and long range navigation. We had to go through what was an altitude chamber. We just went into a chamber, and they would seal it in both ends and then withdraw all the air, simulate that you're up at 20,000 feet. No, they simulate up at 25,000 feet. And we'd be in there for a while to make sure that everybody was breathing. Of course, they had instructors at both ends. You only had maybe 5 men on each side, so they could watch everybody. And of course, they they did experience that. The stories that we told anyway, that somebody would be upset and didn't want to be in the service anyway, and they would take the oxygen mask, unhook it from their oxygen mask and hold their hand there, and they died.
Wow.
Without oxygen.
Inside the chamber?
Because you were in there for a while. 20,000 feet isn't that bad, but it just saps the oxygen right out of your blood. And then you expire. But they were very I think they had 4 instructors, 2 on each side, just watching out for everybody and making sure. And besides that, we also had to go through a gas chamber. We'd have to put our oxygen mask on, our gas mask on, and walk into a chamber, and you're locked in there. And you can sit down or stand up, whichever you want, on benches on the side, and then all of a sudden they told me, remove your mask. It's loaded with tear gas.
Wow.
And if you didn't take it off, they took it over and they ripped it off for you. And at the same instant, both doors were open, and you run out coughing, sneezing.
But they wanted you to at least
to
be exposed
experience
to it.
what it was to. No one ever got hurt or anything from it at all. A lot of cursing and swearing, you know, good son of a bitch.
So they didn't warn you about that ahead of time?
No, they didn't warn you about that.
So talk about, you said you flew you did a lot of training in that airplane in Arizona.
Right.
How's the plane laid out? There's 10 of you in there, but where are you guys?
Well, the pilot and co-pilot was in the pilot's seat. The 2 engineers swapped between the nose turret and the top turret. And the navigator and the bombardier, the bombardier was underneath the nose turret in here, and he's operating the bomb sight. And the navigator is just standing here at his desk behind the nose turret, going with his charts and everything, and his sextant. And in the back, you have a ball gun. They drop the ball gun and the ball turret, and 2 waist gunners and 1 tail gunner. So we did all our shooting from all the guns.
Now, were you able to do a lot of shooting on these Arizona flights?
Yeah, we were from air to ground. That was all. Mm-hmm. In training in the bomber, it was only air to ground, and we'd be riding around the desert, and they come along with a wooden mock-up of an airplane, and you're flying 160, 170 miles an hour, and the plane goes out that way, and you got to move to go that as fast as try to hit something. Very rarely, I'd look, instead of shooting, I would look down there, and ain't nobody hitting those planes.
And those weren't moving?
No. So
you trained there for how long in Arizona?
We were there for 6 weeks, that's all. And we were fun. In fact, it wasn't 6 weeks, it was only 3 weeks there. Then we were given 10 days leave. And being on the east, we were in Tucson, Arizona, and given the 10 days leave and the 3 days to go in each direction. I was only home for 4 days. But we come back to Alamogordo, which where they was right next to where they were creating the atom bomb at White Sands, and
you didn't know that at the time, or did you?
No. I did know something about a place like that because my brother went in the Navy, and he was in college at the time and at Cornell University, and he was kept there in V12 learning. But while he was there, he was offered a job that he has to go away for 6 months.
Good afternoon. Thank you for joining us today. My name's Teresa Miller, and I have the privilege of serving as the Secretary of the Department of Human Services. At the end of June, the Wolf administration issued an order to personal care homes, assisted living residences, and intermediate care facilities licensed by the Department of Human Services, requiring universal baseline testing for all residents and staff in these facilities by August 31st, yesterday. This was an extension of a baseline testing order issued for nursing facilities overseen by the Department of Health at the start of June. In July, the Department of Health reported full compliance with this order, and today we are proud to announce the same for the nearly 1,400 personal care homes, assisted living residences, and intermediate care facilities licensed by DHS. All have completed baseline universal testing for residents and staff. Through this effort, more than 127,000 residents of long-term care facilities were tested, setting a foundation of assessing the presence of COVID-19 for the nearly 2,000 facilities covered through these orders. But while we are proud to mark this accomplishment and are grateful to our long-term care network for recognizing the need for and value in this baseline testing, we know this is just a step in our continuous work to protect vulnerable residents and staff of long-term care facilities from COVID-19. COVID-19 is still a very real threat, but we are better positioned now as we head into the fall and flu season with the knowledge and experience that we've gained in the first 6 months of this pandemic. We must learn from experiences of the last 6 months and continue to strengthen prevention and response efforts as this pandemic evolves. Protecting medically fragile and vulnerable residents of long-term care facilities requires constant vigilance, and this universal baseline testing is a critical step in allowing these facilities to know the status of COVID-19 in their facility, and that will inform mitigation efforts and steps necessary to keep residents and staff safe as we move into the fall. I'd like to take a few minutes to thank and recognize the health system partners who were invaluable in this testing process and made it possible for so many facilities to meet this requirement ahead of the deadline. The Regional Response Health Collaboratives, or RICs, have worked tirelessly since they were selected just 6 weeks ago to support facilities as they completed this universal testing goal. The RICs replaced the Education Support and Clinical Coaching Program, which was a voluntary program that we created this spring in providing operational, clinical, and administrative support for long-term care facilities as they protect their residents and staff from COVID-19. This network builds on the Education Support and Clinical Coaching Program's successes and continues to support long-term care facilities across Pennsylvania as they respond to COVID-19 by assessing preparedness to properly respond to a COVID-19 outbreak, support with best practices in infection control and implementation of other COVID-19 mitigation efforts, testing and contact tracing efforts, and on-site and virtual clinical consultations. Health systems assigned to each region are the Thomas Jefferson University and the University of Pennsylvania in partnership with Temple University Hospital in Southeast Pennsylvania, Geisinger Clinic and Lehigh Valley Hospital in Northeast Pennsylvania, Penn State University in South Central Pennsylvania, Geisinger Clinic in North Central Pennsylvania, UPMC Community Provider Services in partnership with Allegheny Health Network and the Jewish Healthcare Foundation in Southwest Pennsylvania, and LECOM Health and UPMC Community Provider Services in partnership with Allegheny Health Network and the Jewish Healthcare Foundation in Northwest Pennsylvania. These health systems are providing direct 24/7 support to long-term care facilities across Pennsylvania and are doing important work to help prepare for and implement policies and procedures that can help mitigate COVID-19 outbreaks at these facilities. This network is designed to be a peer support system for the long-term care system. The RICs are not regulatory authorities. They exist to support an environment where facilities and health systems can work together to assess, strengthen, and implement preparedness plans and mitigation strategies that will keep staff and residents safe amidst this pandemic. Long-term care settings offer different levels of care, and less acute settings may not have on-site clinical support necessary to navigate the pandemic. The RICs help fill this role by being an accessible support that can triage issues as they arise or be a trusted source that long-term care facility staff can turn to for questions or concerns. In the 6 weeks since the RICs have been in place, they have worked quickly to be supportive and responsive to needs of long-term care facilities around Pennsylvania. RICs are completing initial on-site visit and readiness assessments for facilities in their region, supporting call centers that are available 24/7 for technical assistance and clinical support, assisting with PPE supply and fitting, and other needs that arise as facilities navigate this pandemic. When a RIC engages with a facility or is called in to help with a concern, these are called missions. Missions could range from assistance with testing, assessing a facility's preparedness, staffing support, rapid response, PPE support, fit testing, and questions or concerns requiring clinical consultation. Since launching, the 6 RICs have been assigned nearly 3,000 missions, primarily covering testing, consultations, facility assessments, and support with PPE. The RICs have made 59 total rapid response team deployments, with 52 of those completed at this time. This is where a multidisciplinary team goes to a facility to assess and stabilize the situation when an outbreak is occurring in a facility. More than 650 on-site facility visits occurred by the RICs as they work to assist long-term care facilities. And the RICs call centers have received more than 500 calls to assist facilities with universal testing, staffing support, educational support, PPE, and testing kits. Their reports are among the data that we're receiving regularly from the RICs that help elevate issues that facilities are experiencing to help inform response and support efforts moving forward. The RICs work closely with staff at the Department of Human Services and the Department of Health and the Pennsylvania Emergency Management Agency to report on experiences with each of the long-term care facilities they're working with and elevate potential issues or areas of concern so resources and supports can be directed. COVID-19 is an evolving challenge. The steps that long-term care facilities are taking with the support of the RICs, Department of Health, Department of Human Services, and PEMA will help to strengthen preparedness and be better positioned to respond to cases and outbreaks if they occur. But cases and outbreaks may still occur. This effort is about prevention and preparedness. We cannot declare mission accomplished, and we are urging proactivity as we navigate the uncertain weeks and months ahead. And we've received really positive feedback about this support network so far. One facility shared that they were extremely worried about an outbreak due to being located in an underprivileged area. And the staff and facility leadership have been carrying the emotional burden and anxiety of a potential outbreak, knowing how dangerous it could be for residents. Facility leadership were incredibly grateful and thankful for the support, and their RIC has built trust and facilitated testing and education that is helping staff feel more confident about their work going forward. We've also heard that in facilities that have received in-person education for frontline staff, those staff are feeling empowered and prepared going about their day-to-day jobs. Frontline staff providing direct care are critical in supporting residents every day, and this staff must feel supported going through their work during this very difficult time. The RICs broaden the scope of support we can provide to these facilities. And beyond their clinical and infection control expertise, the emotional support and companionship they can provide to long-term care facilities will be invaluable as we move forward. All of us know that this spring was difficult. Unfortunately, we are not out of the woods with this pandemic, and the threat of COVID-19 is still very, very real. But our long-term care facilities are not alone in this fight. The RIC Network and the Wolf Administration are here with them. We remain keenly focused on what we can do to support these facilities as they work to protect some of our most vulnerable Pennsylvanians, and we will work through what comes next together. Thank you again for joining us today. Before I turn it over to my friend and colleague, Secretary Levine, I just want to publicly thank her and her agency. Our agencies, along with PEMA, have been working very, very closely together to provide the supports that we need for these long-term care facilities. And I just want to publicly say how much we appreciate that partnership. And now I will turn it over to Secretary Levine.
Well, good afternoon. Thank you so much, Secretary Miller. I share our thanks working with you and all of the RICs and all the collaboration with PEMA and the Department of Military and Veterans Affairs and the National Guard, really all agencies working together for these vulnerable patients, individuals in Pennsylvania. So, the universal testing for all of the long-term care living facilities has been a significant undertaking for both of our departments. And I'd like to thank your team, who has done a fantastic job at ensuring that universal testing was completed right on time. Universal testing in long-term care facilities is an essential piece of our efforts to prevent and mitigate future outbreaks of COVID-19. Now that we have completed 100% of the testing in the skilled nursing facilities that we license and the personal care homes and other facilities that you license, we know and we now have a baseline to know the true scope of how the virus has impacted residents and staff at those facilities. It is because of this testing that we have actually been able to identify cases and outbreaks earlier and provide resources to facilities to help mitigate and deal with those outbreaks. But as you've pointed out, our work is far from done to protect residents and staff in long-term care facilities. We all have a collective responsibility to prevent the spread of COVID-19, and we must be united in that effort. So please remember that when you are wearing a mask in public, when you go out in public, indoors and outdoors, you are stopping the spread of COVID-19. When you wash your hands and you use hand sanitizer, you are stopping the spread of COVID-19. By avoiding large public gatherings and by practicing social distancing, you are stopping the spread of the virus COVID-19. And obviously what's most important for everyone in Pennsylvania to remember is stay calm, stay alert, and stay safe. We are now available for questions. Yes?
Secretary Levine, the New York Times put out a piece over the weekend about testing, talking about a potential of overinflation of testing numbers coming back through the PCR of like 90%. Can you clarify within those PCR tests the level of virus it's detecting, the threshold? Is it catching it when it's contagious, or is it catching it when it's after the contagious stage? Can you elaborate on that at all?
So the PCR test is a very, very accurate test. It is very sensitive and very specific. And it's called a polymerase chain reaction test. And it's testing for the presence of the DNA, of the nuclear material of the virus. And so in terms of the incubation period, it takes several days. But it will test for the presence of the virus itself, the DNA of the virus.
Is there is there a uniformity to the level of the virus that the PCR is detecting?
Well, there are many different PCR tests. I'm sure that they have some variations, but we are very confident about the accuracy of the PCR tests. I mean, all the laboratories that are performing these tests are CLIA approved. They're all, the tests themselves are approved by the FDA. And so we do not have concerns about the accuracy of the PCR tests.
With that said, have you identified a threshold? Is it catching the virus in the contagious stage, or is it showing you that the folks may have had it and they've already passed it, which is why they're showing no symptoms?
So we know that there are patients who are completely asymptomatic through their entire course of having COVID-19. There are others that might not have symptoms, and then they do develop symptoms, sometimes very mild symptoms, sometimes severe symptoms. The virus, the PCR test will be detecting the presence of the virus, whether symptoms are there or not. So if the patient doesn't have symptoms, you can still detect the virus from the test, and if the patient does have symptoms, you can detect the virus from the test. And it's a very, very sensitive and specific test. Yes?
You've completed baseline testing in care facilities. I know in the past you talked about trying to ramp up complete testing for the population, especially with schools opening, and also I believe that according to the Johns Hopkins list, we are at the bottom of the 50 states in testing per capita. What is the plan for testing outside of nursing homes?
Sure. So we're still continuing to work to expand our testing capacity. We now, on average, are testing 22,600 patients every day. We get those test results back every day, and we need to expand that more. I think that the new antigen tests, which are different than the PCR tests, these are testing for the surface proteins of the virus, I think will be a big help in terms of our expanding those point-of-care tests. The CMS, the Center for Medicare and Medicaid Services, will be sending those testing platforms, the machine, to all of the nursing homes in the state, not the other facilities regulated by DHS, but CMS is sending those to the nursing homes. Only a dozen or more have received it so far, and we'll be working with them, but eventually they will be receiving those test kits, and I think that's going to help our retesting protocols of staff and residents that are necessary really well. I think that as we expand that testing, we had a press conference with OraSure a couple weeks ago. That's exactly the type of tests that they are developing. We're hoping for those tests by the fourth quarter of 2020, and that will be a simple nasal swab that you don't even need a machine for. That can be done right at the bedside or right at the tabletop, and I think that's going to be able to expand our testing. We do not have the ability to test every single person in Pennsylvania, that type of population-based testing, but it's going to be those rapid antigen tests that allow further expansion of testing.
Can I ask, is there a specific group that you are going to focus on next as a vulnerable group?
Well, we want to expand testing in other vulnerable communities. That's really important in terms of health disparities. So we want to make sure, for example, that minority populations have access to testing, African-American populations, Latino population. We had a press conference last week with the Latino Connection. I have personally spoken with the Pittsburgh COVID-19 Black Coalition about expanding testing in collaboration with Dr. Bogan, the health commissioner in Pittsburgh at FQHCs, federally qualified health centers. So I think that it's really important to be able to expand testing to minority communities. And so we'll be emphasizing that as well. Yes?
Assuming that the point of universal baseline testing is to kind of gauge where there's COVID that we don't know, right? Can you say how many facilities you actually discerned had it that didn't know they had it?
So I don't have a specific number at my fingertips, but there were a number of facilities, both. We can try to get you some more granular information about that, but we know that there were nursing homes and then also other long-term care facilities that had individuals that were asymptomatic, both staff and residents, that were detected using this testing. Would you like to further respond? Sure.
At least for our facilities that just completed their testing, yesterday was the deadline. And so we had 1,400 facilities that each submitted separate paperwork. So we will make this public. Right now, we're just going through 1,400 different documents to figure out what that number looks like. So we do anticipate publicly reporting that as soon as we can kind of collect it all and put it in one place.
And then just as a follow-up, the answer is, there must be retesting planned. And the way you had described it previously was if we found it the first time, then we would kind of test more. Can you explain sort of where
Sure.
things stand as far as retesting in facilities?
So there is some specific CMS guidance that came out last week about retesting, and so we're going over that, and then soon we'll be putting out to our facilities the retesting guidance for the skilled nursing facilities, the nursing homes that we regulate, and I believe Secretary Miller will be doing the same for the facilities that she regulates.
But you can't shed any light on what that guidance is.
The guidance, I mean, there's specific guidance in terms of testing staff that depends upon the prevalence of COVID-19 in the counties where they're located. So what we have said all along, and this is born to be true, is that the prevalence of COVID-19 in any of the facilities that either of us regulate is directly proportional to the prevalence of COVID-19 in the counties where they're located. And so there are retesting protocols that depend upon what that prevalence is. Yes?
So now that you have the data, you've tested everybody once, right? Nursing homes and long-term care facilities. Is there anything we've learned, or you still have to go over the numbers to pore over it? Is there any aha moment about this disease as it pertains to those facilities?
I think that what we've learned is exactly what I've said, is that it is asymptomatic individuals, asymptomatic staff who are courageous and brave to be working in those facilities, helping the most vulnerable among us, who unwittingly bring the virus into the facility. They have no symptoms, but through the universal screening testing, we have detected staff that are positive. And then, of course, those individuals are isolated, and they're at home, and they're not in the facility. But we have detected that, and so it validates what our academic partners have been saying all along, is that it's asymptomatic staff that bring it into the facility through no fault of their own. And by the testing and then the retesting protocols, we're going to be monitoring that and working to prevent that.
Well, I just ran the numbers for today, and we're still at 67% of the deaths are in those facilities, which ranks us higher than most other states. Some are higher, but we're higher than most. Why is that? Have we learned anything? Obviously, we're now 6 months into this.
Sure.
As to why that's where a majority of those deaths tragically continue to happen.
So what many states, in fact most states, have found is that the majority of deaths, and the specific numbers, are among seniors, particularly seniors with chronic medical conditions, which is exactly the population that's in the congregate settings that we're discussing. The most ill are in nursing homes, skilled nursing facilities, but other very vulnerable individuals are in the other facilities, personal care homes and assisted living and other facilities that are licensed by the Department of Human Services. Some other states saw less increases in numbers and death in the spring. So I'll give you an example, Florida and Texas. But because of the significant increases that they had this summer, they also have seen significant increases in terms of the number of patients, residents with the illness, and tragically the number of deaths in these facilities. It is the most vulnerable among us for this very dangerous respiratory virus, which is why we're going to all the different programs that we have outlined, the RIC programs that were outlined by Secretary Miller, the testing and then retesting protocols to try to prevent and mitigate the spread in these facilities.
And my last question, Department of Justice obviously was announced last week, is looking into the nursing home situation. And they're not going to comment on the specifics there, but in your looking at what has happened over the last several months, have you learned that, oh, maybe we made a mistake here, or maybe, so for the next time, hopefully there isn't next time, but if there's a next time, we can react more quickly in that to those populations?
So, I cannot comment upon the Department of Justice letter, and we're reviewing its request for data. I think that there are two big differences, which have been outlined today, of what we're doing now. One is that we're doing this testing. That testing was not available anywhere in the country in March and in April. I mean, in March, we were able to do the first test in Pennsylvania at the beginning of March. And in April, there was significant shortage of testing supplies, testing reagents. And so we were not able to do the type of testing that we have just done to detect those asymptomatic staff that are bringing it into the facility, to detect patients who might have contracted it and are asymptomatic, and then immediately isolate them and do cohorting within the facility. So we did not have that capability then. We do have that capability now. The other is the RIC program that was being discussed by Secretary Miller, working with these fantastic hospitals and health systems to really provide even more support than was possible in the spring now. Anything you'd like to? Okay.
That's great. Positive question.
Yeah.
Secretary, in reviewing the most recent death data as of August 28th, the number was 7,655 deaths, and then there was a note in the report of 37% of those deaths, roughly 2,800, did not have comorbidity data. Is there a reason there's a lag now, so many months in, of having providers get that data to you to outline if they do in fact have a comorbidity?
So the death data comes in a different way. So it does not come from NEDS. The death data comes from the electronic death reporting system, and it takes time to be able to investigate and get the information such as comorbidities on all of those patients. So it does take time to be able to collate that data, but through the electronic death reporting system and the different information, sometimes chart reviews and things that have to happen to get all that information. But we're always working on it.
Thank you, Secretary.
Great. Thank you so much.
They would do anything. They were Australians. They were a wild bunch. But we never did any. There was only one low-level mission, and that was the first mission over Ploiesti, the oil fields in Romania, and that happened just about a week before we got to